Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athlete trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this week's episode, we are bringing back another education episode, and we're going back to the knee. I feel like we haven't talked about the knee in a while. For this episode, we are going to be talking about PCL injuries.
Yes, and this is a CEU episode, so if you're interested in that, make sure you check out the show notes for the most updated links. Thank you so much to Clinically Pressed and Athletic Training Chat for sponsoring these CEUs.
So, for this episode, as with any pathology education episode, we will be discussing the anatomy, because why not, and the biomechanics of the posterior cruciate ligament. We'll be examining the rehabilitation concepts for PCL injuries, and then we'll discuss some of the return to play process after a PCL injury.
Sweet, let's get into it.
Yeah, so the PCL is divided basically into kind of two bundles, right? There's two bundles that kind of join together that makes the ligament that we know as the PCL. One of the bundles is the anterolateral bundle. This bundle is a little bit larger and stronger between the two. And then the second one is the posteromedial bundle. Essentially, when you kind of look at where they kind of start out at, they both originate from kind of like the inside of the medial condyle within that intercondylar notch, right? So they're almost coming off that medial side of the medial condyle, and it kind of travels kind of posterior and lateral until it kind of joins in just posterior to the tibial plateau, 1 centimeter distal to the joint line, basically, so you don't have to pull out a ruler. It's just superior to the popliteus muscle belly.
Okay, that's good to know.
Yeah, so it kind of comes out of the knee a little bit. I was a little surprised to kind of see the drawing. It was like, oh, that looks like that comes out a little bit. It's kind of close to the PCL, the popliteus muscle.
Right. You can kind of see it when you look at MRIs and see the dark black line that goes so much further than the ACL.
It does. Yeah, it's pretty trippy. It's kind of cool. But essentially, those two bundles join together right where they insert. So that's where they'll actually combine together and kind of attach onto their kind of insertion site.
Sweet.
So now that we know what it kind of looks like, where it goes, now it's time to talk about what it does. All right, so overall, I feel like everyone kind of has the idea that the main job of the PCL is to resist that posterior translation of the tibia. I feel like that's kind of, everyone kind of knows that by now.
Mm-hmm.
And that is a really big job of the PCL, and it really does this throughout all ranges of motion. Kind of reading was kind of interesting that when they initially were looking at the mechanics of the PCL, they kind of viewed it as like each bundle was kind of like dominant in certain like ranges of motion, right? And really both bundles kind of share the role, just one is a little bit stronger than the other depending on knee flexion. So up to 90 degrees of knee flexion, that posteromedial bundle is kind of taking on more of the load of resisting the posterior translation. And then anything above 90, the anterolateral bundle is the more dominant one. So they both kind of share, the anterolateral bundle is still active during like less than 90, but it's not the predominant restraint, if that makes sense.
Mm-hmm.
But what is interesting, and I don't think a lot of people kind of consider, but the PCL does serve a role in stability of rotational stress, right? And this is really seen on anything above 90 degrees of flexion, where it actually starts helping with the rotary stability of the knee. And what's interesting is when I was reading, there really wasn't a definitive direction. There was some that says it helps with internal rotation. So like if they were to cut the PCL, there was like increased internal rotation.
Mm-hmm.
And then like another study, there was increased external rotation. So it does all. That's what I've come down to.
I guess it depends on which bundle, right?
Yeah, it could, for sure.
Well, actually, I guess if it's fully cut, then you don't care which bundle it is.
Yeah. But I thought that was interesting that it's whatever it's feeling that day. It's a no bones day.
It could also be the structures around the area.
It is, and
since we do have multiple structures in the knee.
And that is one thing that's interesting about the PCL that we'll kind of talk about when we're talking about kind of like the evaluation and rehab is the PCL is really close to a lot of other ligaments. So a lot of times if this one fails, right? I mean, you can have an isolated PCL tear, but because of the just high force it takes to damage the PCL, a lot of times there are other ligaments that could be damaged, which would then contribute more to the rotary instability and just the issues that you do see after a PCL injury.
I feel like when I've gotten PCLs, it's been standalone PCL.
The only one I've had was, at least I'm pretty sure, was just a isolated PCL.
I feel like that's what I was surprised about, like going from school to being certified. It was like the opposite. You know how quicksand, like when you're a kid, everyone's like so scared of quicksand, and then I don't think I've ever seen quicksand in my life.
I've never seen quicksand.
But
they're all in the cartoons.
But I feel like for the opposite for school, it's like PCL. Everyone's like, don't worry about PCL. Like you'll never see a PCL. I've seen so many PCLs.
That's crazy.
And actually, most
you
of them
see a lot of
them are from women's basketball.
Really?
I've only had one in football, and I've had a couple in women's basketball. And I'm trying to think. I feel like I feel like most of them have been coming from women's basketball. I'm trying to think of where the other ones.
I mean, I kind of get it because like falling, like I could see that. But that's interesting. That's women's basketball.
My football one was actually a lineman who was in a knee brace.
Oh, that's unlucky.
And I was actually able to evaluate him with the knee brace on, which I don't normally do.
Yeah.
But on the field, just that translation.
Yeah.
It was a lot of translation.
Well, plus those knee braces aren't really.
They're not made for
the
that,
PCL.
Right?
That's interesting. That's cool. I mean, not for the kid, but that's cool.
Right.
So, speaking of the evaluation process, like we were kind of alluding to, a common mechanism of injury for the PCL is anything that's going to cause the tibia to just posterior translate too much, right? This is very common in motor vehicle accidents, right? It's referred to as like the dashboard injury, right? Because you're sitting and then you get in an accident, you are forced forward into the dashboard and your knee's already in flexion, right? But in athletics, right, this is commonly seen when the athlete falls on their knee, commonly with a plantar flexed ankle, right? So that literally that anterior tibia is taking the full brunt of the ground.
This is actually when I had the football player with the knee brace, and there are different kinds of knee braces. I think I want to say he was using a Townsend where the metal was in the front of his knee.
Oh, okay.
Instead of the Donjoy where the metal's in the behind the calf.
Yeah.
Which also I was thinking could have created more of a force.
Maybe, yeah.
As he fell on his knee, if it created more of a force to posterior translate his tibia.
Yeah.
So I was wondering how much that played a role.
Yeah, that's interesting. I mean, I feel like maybe. Right, just the force coming through the ground, that already kind of being there maybe pushed it more.
Right.
That's interesting. This is actually the athlete that I had with a PCL injury. She had the textbook mechanism like this. It's funny because this was the day before camp, soccer camp started.
Dang.
She was playing with her dog.
Oh no.
And she fell. And I looked at her and I was worried about PCL, and then she's like, "Oh, I have the video." I was like, "Can I see?" And yep, you could see it, right? She just fell, boom, right on her knee. I'm like, "Oh yeah, you're PCL."
I had another one in soccer too.
Oh, you did?
Mm-hmm. And he didn't know.
You did have a lot of PCL.
I know.
Injuries.
I've had a lot of PCLs, yeah.
But even though the mechanism's pretty consistent throughout, and that's a pretty strong mechanism for tearing your PCL.
Right.
The common complaints, again, I thought were really interesting because each article was kind of a little bit different on what they kind of reported. Patients will kind of complain about. Some said there may be some instability. They might still kind of feel like the knee's unstable. And then some said, they really won't complain about instability. Cool. I'm gathering the PCL is just, it could be anything. They can complain about anything.
It's not textbook.
And I wonder how much of it too was how many other ligaments were damaged in those reported studies. In general, right, you're going to have pain over the posterior capsule, which I feel like that is like a common thing. Like a lot of times when I have those athletes, they're like, oh, I have pain back here.
I feel like I'm trying to remember the last PCL I had was last year. So I don't even remember where they had pain, but I feel like it was just kind of diffuse.
Well, that's the interesting thing is as the more chronic PCL tear gets, like the more it's just kind of put off, they can actually start complaining about anterior knee pain.
Oh,
which I thought was very interesting. And I think it's just the shifting of forces within the knee joint. And now it starts to put a lot more stress on that kind of medial compartment, like with the meniscus and then the patellofemoral joint as well. So I think that's where you kind of get like, okay, now that anterior knee pain is going to start coming into play. And again, another interesting thing is effusion may or may not be noted. I like how it could be either. Yes or no.
Sounds like the theme of this episode.
It does. I'm pretty sure my women's soccer athlete, she had effusion.
My football player did. One of my basketball players did. Soccer did not.
Ooh, that's interesting. That's interesting. How the human body's cool.
I'm glad you think so.
So now, as we go through our eval, it wouldn't be talking about eval without a special test. We got to talk about some special tests. And again, I had a tough time kind of finding a lot of literature on the actual like metrics of the special tests we use.
I feel like sometimes it's hard to find.
It is.
Like validity, which is weird because I feel like if you have a test, you should probably validate it.
Yeah, we should make sure this works effectively.
Right.
But you know what? The classic PCL tests that we have are actually pretty solid.
That's good.
All right. They're all very specific. So if they are positive, yeah, you can feel pretty confident.
Well, I feel like nothing really else translates it except the very first PCL I had. I thought it was an ACL tear because I did the posterior drawer and the anterior drawer. And I didn't, this was like, I had a PCL tear before I had any ACLs. And I thought that it was like, just because of the translation, I was worried about their ACL.
Yeah. I've heard that too.
That
like
that was a mistake that I made.
It could give you that kind of false, because you feel when you do the anterior translation, you feel how much more it moves. And you're like, oh, that seems bad.
Right.
So I think, when we evaluate PCL, right, I feel like everyone kind of does that posterior drawer, and the specificity again is like 98%, right? So it's a 0.98. Right, that's really good. That's almost batting perfect. What I really loved about these tests was the sensitivity had such a big range.
So if it's negative, you can rule it out.
Yes. Yeah. So if the test sensitivity would basically say, oh, if it's negative, it's definitely not this. So the range for the posterior drawer was 22 to 100%. That's a big range.
So you might be able to rule it out if it's negative, but you might not.
Yeah. Just know if it's positive, that's a good positive. The next one was that posterior sag. So for that one, it's literally just knees bent on the table, and you're just looking from the side to see if the tibia is just kind of shifted posteriorly. Again, specificity on that bad boy, 100%.
Have you seen a posterior sag?
My women's soccer athlete. That's what kind of keyed me. Well, obviously the effusion, but then as I was looking at it, I was like, oh yeah, that doesn't look good. And then I went into the next test we're going to talk about, and that was really cool too. But we're not there yet.
I feel like
did you have the posterior sag on?
On all of them.
That's so interesting.
For what I think is really, well, if you think about your ACL, like when athletes guard or when patients guard, the hamstrings are really there to keep the tibia from translating anteriorly. Yeah. Whereas really, you don't have much from keeping the tibia posteriorly translating except for your quads.
Which is, when you have it in that knee flexion, it's not really
And it's just one point. That, like, at least the hamstrings attach at 2 points.
Yeah, but that angle, like, there's not even enough pull to keep it from. So that brings up a good point. And then the sensitivity again, big range. We're looking at 46 to 100% on the posterior sag. So if it's negative, maybe it's not, or maybe it still is.
Just rely on the positive.
Yep.
We're just staying positive.
And then the last one that, that again, I feel like a lot of people are pretty used to is the quadriceps active, right? So this is where they're still in that like kind of knee bent, feet on the table, but they do a small quad activation, and then if the tibia shifts anteriorly.
I don't think I've done that.
Oh, my women's soccer player had it. And it was pretty cool to see. It was pretty trippy. And you actually see it shift forward and like, oh yeah,
that's crazy.
That's not supposed to happen.
Again, I have
Again,
someone with a PCL. Is this so? Like, I have someone with a PCL deficient knee
ooh, interesting.
from an injury last year.
Yeah,
Would it still work on them? It should, right?
it should.
I mean, she completed her entire rehab.
It should, because the
She's
laxity
returned to
could
play.
still be there.
Mm-hmm.
So it should.
I'm gonna try it on her today.
Yeah, you should try it. Specificity 96 to 100%. And then again, the sensitivity on this one is a little bit better of a range, between 53% and 98%. Not bad.
All right, so we're still staying positive.
Yes. It was interesting. They kind of had, there was one part that I read that had kind of a cool grading system to it. Like, obviously, like sprains, like we all know that grading system. But what I thought was very interesting is, like, kind of going into that posterior sag test, when you're actually observing, you can actually grade what kind of PCL tear it could be. So like a grade A would probably be like something that's like either normal or probably like a grade 1, where the tibial condyles are still a little more anterior compared to the femoral condyles. So kind of pretty close to what like your normal knee would kind of look. Grade B would be like the tibial condyles are even with the femoral condyle. So this is kind of like how I looked at it. Was like, oh, but that's probably like your grade 2, like maybe a partial. And then grade 3 is where the or grade C in this case would be the femoral condyles are more anterior compared to the tibial condyles. So I thought that was something kind of easy that you could already start to get an idea when you're going into your eval of how significant this tear might be, just based on the posture of the tibia. So I thought that was kind of interesting.
It's weird to hear you say grade A, B, C.
It was really hard to read it because but like that's how I kind of viewed it, was like it kind of equated to grades 1, 2, and 3. Like that's just it. Yeah. I mean, there's other ways they can grade it, like on stress radiograph, like X-ray, like how much the tibia actually translates, or you could kind of do it yourself. Like if, like when you're pushing, like, oh yeah, that's 10 millimeters of translation. But I feel like no real person does that. Right. So, I mean, that's kind of hard too, to measure that. So that's why I thought this one, that kind of like measuring system, I thought was kind of like, oh, that's pretty useful. I was kind of a fan of that. And then like there were a bunch of, like, they kind of talked about other tests that can be used, but I think they really tended to go into more of the multi-ligament damage that could be seen. Right. So like dial test. Right, that one can be used for PCL, but also posterolateral corner injuries. But it's also important to, if you have PCL damage, to also rule out LCL, MCL, ACL, any meniscus damage.
So basically do your knee eval. Like do a normal knee eval.
Yes, do your normal. Just because posterior drawer was positive doesn't mean we stop there. Like, okay, PCL's gone. I already know. I'm done.
Right.
And maybe rule out some of the other ones.
But again, and maybe I'm just not aligning with the literature, but all off the top of my head, all of my PCL, and I've had at least 5, all of my PCL injuries have been just by themselves. I don't think I've had, other than like, maybe I've had like a ligament sprain or a ligament tear associated with a PCL sprain, but I haven't had any PCL tears that have been associated with anything else.
Interesting.
Just standalone.
My sample size of 1 is also agreeing with that.
Right. So there you go. You have like at least 6 that don't agree with the literature.
This is a great study. So now that we kind of evaluated it, right now we're trying to, okay, let's rehab this bad boy. And for kind of like your low grade PCLs, like so grade 1, grade 2, right, non-surgical is pretty much going to be your first line approach, right? We're really not going to jump to surgery for this. And really, like in high grade tears, like you might be able to get away with a non-surgical case if it's basically asymptomatic, or if they're in kind of like a low demand sport. For someone who is pretty symptomatic, right? Like they have that sense of instability. Maybe they play football, right? Surgery might be needed at some point, possibly. That's kind of what the literature was going with. But it's for sure like if they tried a case of a non-surgical approach and it didn't work, then surgery is probably gonna be like, okay, we got to do that.
I've not had a single person go through PCL reconstruction.
You know what's funny is I don't really hear of it that much.
Yeah.
Like I feel like most of the time they were all treated.
That's like a question for our ortho who probably sees them more.
For sure. And I wonder how new that thought process is to just kind of jump to the surgery on a complete rupture.
Right.
So, I'd be interested to see like how new of a thought process that is.
I mean, even my basketball players, one of them was braced, and then I've had others that I think only one of them has been braced. The rest,
which the braces for just PCL are kind of trippy.
I do not remember what brace we used on her.
Everything I was reading was referring to what's called a jack brace.
We definitely did not use that. I don't know what that is.
And basically what it does is it adds anterior translation to the tibia to basically shorten the PCL so it heals like in a more optimal way. So it's not like as it heals, it gets like super loose. Right. Because the nice thing with like the PCL is it does have actually a pretty good blood supply. So it does have the ability to heal like without surgery or without being reconstructed. It's just as with most structures that we try to heal, right? We try to get the ends nice close together and like make sure it's not like super stretched out, right? So that's the idea of kind of being braced with that like special jack brace. And that's really kind of where a lot of conservative care goes to when they do that. Like they're supposed to wear that brace. Shoot, I think it was like the literature was saying like 12 to 16 weeks, like continuously. So that's like walking around, doing, rehab, like they're supposed to be in this brace. So I thought that was crazy. I'm like, our women's soccer athlete definitely did not die. That would have been nice if she had that. Right. But for conservative care, the rehab tends to be, from what I was reading, like it was interesting. Like some things were like, oh, like 2 to 4 months. But then I was looking at the protocols and I'm like, this goes up to like 6 months. So like, I feel like it's like 2 to 6.
Yeah, but I wonder if it's also like they can be doing stuff.
Yeah, because like I think, but like some of the stuff that I was reading on the pro is like return to sport was right around like 24 weeks. And I'm like, I feel like if I'm reading 2 to 3 months, 2 to 4 months, like month 4 would be that return to sport-ish. So that's why I was like, I think some conservative ones go a little bit longer, probably depending on severity too. I mean, that also plays a role. But essentially those early phases are geared toward restoring your motion, right? Getting our knee range of motion back, decreasing knee fusion if there is any, right? And then improving our quad activation, all while trying to protect that healing PCL. All right. So the big thing is really no isolated hamstring activation for a minimum of 6 weeks, where some studies even went 12 weeks without actual isolated hamstring activation. Because remember, the hamstrings, when they pull on the tibia, they're going to add that posterior translation, and then we're just defeating the purpose of trying to heal the PCL now. Right. All right. And to try and do this, to try and protect that PCL, right, patients are going to be pretty much in a brace throughout this process, right? Those first like kind of 2 to 4 weeks, they're going to be locked into a knee extension, right? So they're not really going to, like, they're stuck in that knee extension, and then hopefully are transitioning to a jack brace that they're going to have on for like 12, 16 weeks. So right there, that's 3-4 months, right there, just in that brace. As the conservative care kind of goes, right, as range of motion gets better, right, they're going to be limited in like closed connect chain activities like squats to about 70 degrees of flexion for at least 4 to 6 weeks. Right, so those early phases, you're really protecting motion. You're not trying to go to these extremes.
I feel like you are it's really similar to like an ACL prehab.
It really is.
Where you're just doing range of motion, you're doing like mini squats, you're doing quad activation, all that.
For sure.
All the basic.
For sure. And that's what I got.
Stuff.
And what's crazy is I felt like this was, like, I don't know, maybe it's because like ACL, you see it more commonly and like you talk about it more. But I feel like PCL was like, it was so strict and a little bit slower on like your motion that you're able to do. Like you're limited to 70 degrees of flexion. It feels like 4 to 6 weeks feels like forever.
I feel like it is because it's a non-surgical.
Yeah.
So you really have to allow it to heal. Whereas
for sure.
With the ACL, you're doing prehab, but then you're like whatever damage you do.
Yeah.
Not that I'm promoting you doing damage. It's going to be surgically fixed.
For sure. Yeah, for sure. Yeah, that's a kind of a good way. Like it's already torn. Like we could just now get stronger for your surgery. Woo. So on the flip side, right, the surgical management, right, the concepts that were taken from the conservative care are literally the same as what they do for surgery. It's just going to be a lot slower, right? This process is going to be about 6 to 8 months. All right, so it's a little bit slower, all right? And just to give you an idea of just how slow this process is, that closed connect chain like knee flexion, right? You know how we said it was restricted to 70. In the surgical case, it can't go past 60 degrees until weeks 13 to 24.
That's a long time.
Right, so you're literally stuck right around 60, 70 degrees of mini squats for, almost like 6 months. Yeah, so I thought the concepts were very similar, right? And in addition to like getting that range of motion back, right, our initial phases are making sure the quads are nice and strong because, again, that's what's theoretically protecting the PCL. Right? That's our dynamic kind of stabilizer there. And then eventually those later stages are now to catch up the hamstrings that haven't been allowed to do anything. So yeah, I thought it was kind of cool to actually see protocols for PCL. Like I would now feel like I have the resources if I had a PCL to make a better rehab plan than just like, oh, I know I need to strengthen the quads.
Yeah. Well, working women's basketball.
I need to work your women's basketball. I'll be ready.
You don't. Nope. Honestly, I've had 3 women's basketball from the same place. All different years.
That's crazy.
Yeah.
What's going on? Why are we falling? What are we doing? All right. So we completed the rehab. Took forever, but we completed it. Now it's time to return to play. Let's get back out there.
We like that. Athletes like that.
This is our favorite word right here. Our favorite phrase, return to play. Really, the return to play is nothing super complex. It's really similar to other pathologies that we've discussed on our education episodes, and it's very similar to what's kind of been done with like the ACL. Right, hop testing. Right, you should be within around 90% of your opposite limb. Right, so the limb that's non-injured. Right, both of them should be able to perform hop testing to a similar degree.
So, question, because I've heard that it depends on dominant leg versus non-dominant leg.
That could create some controversy. Also, another consideration is how did you necessarily get your baseline? Because if you're immobilized for a while, the non-injured leg could become weaker because you're not necessarily strengthening it like you were before. So are you getting an actual number? Also, if you had a surgery, sometimes you could get some of the detrimental effects from surgery to a lighter degree on the opposite leg. So this is when sports medicine and the literature says, do your best.
Yeah.
Good luck. But yes, those are all considerations, and that it really kind of depends how you do it. So what I try to do, at least for my surgery cases, when we're doing our prehab, before they go into surgery, I try to do the hop testing on their healthy leg before the surgery, because
I've never. I usually do it at the same time at the, like I'll do, we all do at my current site. We do a functional test that
nice.
One of my co-heads got from a PT clinic, and we basically do the uninvolved limb and then we do the involved limb, and we just compare it as they are now.
Nice. And I think
if it's their dominant leg that they injured, then we get it to above 100%.
Oh, that.
And if it's their non-dominant leg that they injured, we get it to at least 95, hopefully closer to 100.
Nice. And that's another thing too. What's your criteria, right? Like it's really how strict you want to be and what you feel comfortable with.
I feel like anytime that you're trying to avoid re-injuring something this major, I feel like it's erring on the side of caution is always better.
For sure. But yeah, it really kind of depends. Yeah. So like that's what I try to do with mine is before they go to surgery, I try to test the non-injured limb, because at least theoretically that should be pretty close to where they would have been like healthy. I do like that aspect of it. If it's their dominant leg, like you try to get it over 100% on the comparison. That's kind of cool. I think that's a really cool aspect. I haven't actually read that in literature at all. Like, I'm surprised no one's brought that up. Or at least I haven't seen it. Maybe someone's brought it up. But I feel like in all the hop testing stuff that I've read, like, no one has ever talked about trying to go above. Everyone just tries to get, like, the debate is always between 90, 95. And, like, some studies did, like, 85. And I'm like, whoa, that's wild. At least I think
Have you seen someone when they're at 85?
Doesn't look great.
No. They do not look ready to go back to sport.
Along with hop testing too, strength testing should be around the same, right? You should be within that 10% of both legs, right? But again, right, the leg dominance thing, that brings up a good question about that. And plus, some people don't have the ability to actually do strength testing, right? Because most time when we think of strength testing, it's isokinetic, which I don't even see that anymore.
You see your handheld dynamometers now.
Yeah, I see the handheld dynamometers. But like I feel like I haven't seen an isokinetic machine in years.
I only know of one.
Really? Where?
In a basement.
Whoa.
And they were trying to get rid of it because they never used it.
Oh. That's interesting. And then again, now kind of going from the kind of subjective reports, right? The athlete should not feel apprehensive, right? They shouldn't feel nervous. They shouldn't feel scared. Right, we shouldn't be returning people if they don't feel right. Another
plug, if you're interested in patient-rated outcomes, the Tampa scale of kinesiophobia would be a great one to use here.
Boom. Yeah.
There you go.
I thought that was needed for patient-oriented outcomes. And then,
look, you even talk about them. I didn't even see that.
Right, and then their outcome measures should be pretty close to what would be considered normal on whatever scale you're using. Like, there's countless number of scales for the actual knee.
The KOOS.
The IKDC.
That's the IKDC is supposed to be like gold standard for most knee injuries, right?
Yeah. I know for
especially
like
for
ACL.
Like athletic.
I think ACL use that a lot. Or can be used a lot because the ACL has their own now. And then I think you could get away with like the LEFS, the lower extremity functional scale.
Well, it depends on if you want to go generic or specific.
Yeah, right?
Or both.
Well, whole person. Might as well throw a short form 36 at him. Even Arrow wasn't about that.
Yep, our dog is now leaving the room.
You don't want the short form? Also, 36 is not a short form.
No, there's a short form 12.
There is a short form 12.
Okay.
There's a short form 12. See, that makes more sense.
Right. If you actually are interested in more patient-rated outcomes, there is a website that we are not affiliated with at all, called orthotool.kit, I think. Orthotool.kit.
Oh, okay.
And it's all online patient-rated outcomes. You can have them fill it out usually, like, if I do it, which is not that often, but if I do, then they're, like, while they're on stim or something. I just have them go to the website, and then they fill it out, and then it generates a PDF. And then you can have them just email it to you.
For sure.
And then you can upload it.
That's cool.
And it scores it for you. That's
the
part.
nice part.
Yeah.
That's nice because those are just.
And it tells you, like, it gives you a little synopsis at the top, tells you the authors, it tells you the summary. It's like
and the resources.
It's a great resource.
It gives the reference.
And references.
Also, what I think's nice with like patient-oriented outcomes, we should probably do an episode on this.
We probably should. That's a good one.
Like everyone gets so concerned about like grading it and the number, which is important, right? We should is putting an objective number and you can see change, and that is important. But also too, I like it to see what they're still struggling with and how we can tailor rehab. Like there's some of them that we'll ask the question about getting in and out of a car, right? And like if they rate difficulty with that, well, we could see that we're having issues with squatting. Or we're having issues with like knee flexion. Like, so I kind of like it from that aspect too. So if you're like someone who's like, I don't want to grade it, I don't want to add up numbers. Sometimes just the information from the questions is nice to use. And it's questions that like it could save you time actually. So instead of sitting there asking them, you can give it to them. Go do something else real quick, come back and be like, oh, hey, I see this is a problem.
Right.
What are you doing? Things
that you wouldn't also necessarily ask.
Yeah.
Yeah,
that too. It's not something maybe you didn't think of asking, right? Or something that didn't just come to mind. Or, when you have 50 athletes, that one slipped your mind because you were doing other things.
Right.
Football.
And it makes it more objective.
But overall, when we kind of looked at the outcomes, right, non-operative care has been very successful for these injuries, right? A lot of people do return to sport. They're pretty happy with how they return to sport. I think there is one consideration for all parties involved is obviously with non-operative care, right? There is going to be a little bit more laxity compared to actual surgical intervention, right? So just taking that for what it is, like patient education stuff, that might be a concern. It's not going to be truly like the native PCL, right? The surgical intervention will get a little bit closer to that. So, that's something to keep in mind, that there might still be some laxity or some like kind of just uncomfortableness with kind of non-operative care. So that's something to consider, right? You'll definitely get a stronger ligament if you were to repair it, if it did need reconstruction, compared to just going non-operative. That's PCL.
What's your action item?
PCLs are slow.
What? Oh, I was like, what are you talking about? The recovery.
Yeah.
You got to go slow with PCLs.
Yeah.
I feel like every PCL that I was thinking of while you were talking about how long they take, I feel like every PCL has not been towards the beginning of a season. I had the football one was a spring football, so it was like it really wasn't like a rush to get back for games or anything.
Oh, that's nice.
They wouldn't have been able to get back for games, but and then women's basketball has all been during season, so it's not like
tough.
Yeah, so it's not like I don't think any of them have returned during season. One of them who is probably the most likely to return during season was towards the end of season. Yeah.
Okay. Yeah, I would just say it's a slow process for the PCL.
So if you like this episode, make sure you check out the show notes to get your CEUs. You just have to go to clinicallypressed.org, find the course, and there's a whole tutorial how to do it on our Instagram as well. There's a video associated with you can just follow the click along. And we also have other CEU episodes you can check out. As we switch as Clinically Pressed and Athletic Training Chat, there are new providers. So we used to have CEUs through Precision AT. So if you find any other CEU episodes previously, we are slowly adding them to the website. So make sure you stay tuned as those get added, as next year is reporting year. So we're trying to get those all up for you. And then we also do more episodes than just CU episodes. We have story episodes where we take stories from athletic trainers across the nation, across the world, and we bring them about certain topics. Last week we did a rugby, and we do different sports stories. We do I think upcoming we're looking at like difficult coaches, someone requested. So make sure you stay tuned for that. We also do interview topics on just highlight topics that we have people, experts in their field, who are able to talk about certain things. So make sure you check out those. If there's anything that you'd like to listen to, make sure you reach out to us, AT Corner Podcast on Instagram or atcornerds@gmail.com. And then lastly, we have a Facebook group where you can discuss this. You can comment on this episode on Spotify if you listen on Spotify. So that's a little bit of a newer thing.
Yeah, that's true.
So you can start commenting. And then other than that, just make sure you check out the show notes for all the other goodies like MedBridge and stuff like that. You got anything else, Randy?
Nope, that was perfect. Thank you for helping us showcase athletic training behind the tape. Bye.